Welcome, dear friends. I'm Dr. Manjunath. There are many names given for this. One is a forced oscillometry, impulse oscillometry, respiratory oscillometry, and the lung oscillometry. This signifies what the oscillometry is all about, and that is the superimposition of the sound waves, which are basically the pressure waves which are superimposed on the tidal volume. Whenever the sound waves go inside the lung and they come back, all these are picked up by the transducer. These are pressure and flow transducer. In turn, you can pick up the resistance and the compliance of the lung, and that is all about is the lung oscillometry. It is probably the simplest of the explanation what we can give, but it just doesn't end there. It is beginning of our entire topic. This respiration is basically a balancing act between inspiration and expiration. The lung muscles work very hard to expand the lungs. Once it happens, the recoil forces of the lung will pull it back to its original shape. During that time, whatever the lung volume left over is the functional residual capacity, which is about 3 liters or 35 ml per kilo or 3.7 grams in an adult. During the time of emphysema, the recoil nature of the lung comes down quite drastically, and that's how the FRC goes up. And in cases like interstitial lung diseases or the so-called lung fibrosis, the lung just doesn't expand enough, and that's how your FRC comes down quite drastically. These two are very important in our further analysis and understanding of the lung oscillometry. What is impedance? All those factors which create the hurdles, resistance, or opposing factors for breathing in turn are called this the impedance. Resistance is the expiratory thing which is picked up by the oscillometry, and reactance in turn has two components. One is compliance and inertance. Oscillometry is all about pressure and flow. Whenever you assess the pressure, you also assess the flow. You measure indirectly the resistance factor of the respiratory system. So you take the analogy of a hose which is used, rather soft water pipe which is used to water the plants. You plug it to an extent, you compress it, the resistance goes up and the flow, in turn causes which alters the flow. This is the Ohm's law, which is indirectly used in our oscillometry. This is a graphical description of the same thing in a different way. Sound waves in oscillometry causes that pressure and flow changes in the airway, which are then picked up by the transducers, which are utilized to calculate the impedance of the respiratory system. We will go, this is a little difficult for us to understand, but I'll try and explain as much as possible. When pressure and flow are in sync in the respiratory system, it measures the resistance, which is a pure resistance in a positive value. Whenever the flow is ahead, the phase, because you are measuring the flow and pressure at different phases. If the flow is ahead of the pressure, it is which measures the elastance or the compliance, which is a negative value. When the pressure is ahead of the flow, it measures the inertance. There occurs this phase shift from negative value to positive value. So this is not really important in how the negative values and positive values are derived at. This is only for the origin and how we depict it in our graphs. Why are different frequencies used? Let's take the analogy of the frequency waves. In olden days, we used to have the AM. If somebody would be broadcasting in Ceylon, and you would still hear it in Bangalore or Bhubaneswar or elsewhere. And in due course of time, we got the frequency modulation. Here, what you need to understand is the AM are the small frequency ones, which could travel a large distance, and the frequency modulation or the FM radio are the large number of, they use higher frequencies, say 91, 90.1, 98, so on and so forth. They have a limited distribution. They go and they dissipate soon, and that's the reason why the smaller the frequency are, the lower the frequency levels are, they can go deep into your system. For instance, abdomen, it's about 2 to 5 hertz, and about general abdomen is about 3 to 7. Vascular and breast and pelvic is about 5 to 10. As superficial you go, the frequency increases. Shorter the frequency, deeper it goes. Larger the frequency, shorter the distance it traverses. The same principle is applied even in oscillometry. So this is how we can depict it. So R5 goes till the tip of the airway, that is the central and the peripheral airways both are traversed and they come back. Whereas the larger frequency does not go a distance in the lung, it just comes back very soon. So if you measure that this difference between R5 and R20, it basically measures the resistance factors difference between the R5 and the R20, or the central and the peripheral airways. Let's understand what this resistance is. The first component is the resistance of the airways. Depending upon the radius of the airways, the resistance of the passage of the airways is determined. Now, the large airways, which from the trachea onwards to the 7th generation, they're called as the large airways. The airflow is not laminar. It is turbulent airflow, and the resistance is 1 over R by 5. From 8th generation onwards, which are medium to small airways, the airflow becomes laminar. The resistance now is 1 over R by 4. Airflow needs to overcome all these forces to travel right up to the alveoli. Resistance is a frictional force. Please remember, resistance is a frictional force. And the depending upon the tract where you're entering, the nose to larynx is about 66%, large airways contribute to 20%, small airways contribute to 7%, and the respirable zone contributes only to the 7% of the respiratory tract resistance. The conducting zones make up to the 93% of the resistance, whereas only 7% of the resistance is caused by the respirable zones. Let's understand what reactance is. Lungs have the spring-like nature which resists the opening of the airways, and this is the capacitance, which is mainly due to the alveoli. The air inside the trachea and the airways also offer some resistance due to its mass, and that is called the inertance. Inertance is perfectly balanced at functional residual capacity. When we breathe in, we have to overcome both the elastic recoil of the lungs as well as the resistance from the mass of the air. Together, these two are called as the reactance of the airways. So you must understand that the resistance is for the airways, the inerty properties are due to the mass of the air, and capacitance is for the parenchyma. Together, these are called as the reactance. The compliance is again is increased. There are in case of emphysema, aging, where the elasticity is lost, where the lungs are not coming back to its original shape, That is when we have to understand the compliance of the lungs have increased, which are not coming back to its original size. In cases like in infiltrative lung diseases, fibrosis and pulmonary edema and ARDS, the lungs are restricted. They're not expanding enough. So you can take it as a balloon, a soft balloon which expands and contracts normally, and a aged balloon which has blown on, have been in the blown stage for a long time. Even after deflation, the balloon doesn't come back to its original shape. It remains at a higher level, and that is depicted as the emphysematous lung, where the FRC is increased. And you can think of a very thick football balloon where it is not ready to expand enough. That depicts the restrictive lung disease. So you can think of a normal balloon, expanded balloon which is not coming back, and the lung which is very thick, a balloon which is very thick, which is not expanding enough. All these depict different forms of the lung compliance. This figure depicts basically the same thing, how it is distributed in the lung. So what we need to understand is resistance is change in flow rate, and reactance is change in the volume. These two are assessed differently by different transducers by the oscillometry, and that's how we get the different factors of the lung, and that's how we interpret the oscillometries. There are different types of oscillometries. One is the mono frequency, impulse oscillometry, and the pseudo-random noise technique. The sine wave, sinusoidal wave pattern, which go into the lung, which are usually 5, 7, 12, 20. That way they go to the lung. They are given a different timeline. Say, in a regular Antlia one, what they do is to give a wave at, say, for 12 seconds. The next one is after 12 seconds and another 12 seconds. That's how you assess the resistance and the reactance of the lungs at different frequencies. Whereas impulse oscillometry, where all the frequencies enter the lung at the same time in an impulse form. Ager was the first company in somewhere in 1980s. They manufactured this one and they called it as impulse oscillometry. Pseudo-random noise is where the prime numbered, like 3, 5, 7, 30, 19, and so on, are pushed into the lung sequentially, and that's why they're called as pseudo-random oscillometry. They have a different reason why it is done. So let's not go into details of all that. The pressure and flow signals are measured at the mouth and used to calculate the respiratory impedance at each frequency. Let's look at the different parameters of the lung oscillometry. We have the total resistance. What is offered is the Z, which is the impedance, which is denoted by Z. R5, the resistance across the entire respiratory tract, or the total airway resistance. R20 is the resistance of the large airways. R5 minus R20 is the resistance of the small airways. And the resistance is frequency independent, whether you are measuring at 5 or 12 or 17 or 25 or 35. The R number just doesn't change much. If there is a problem at a particular level, for instance, you have R20 increase, the resistance is mostly at the upper airways. If the resistance is more at the R5 levels, the resistance is more at the peripheral airways. So difference of that will help us understand where the pathology of the lung is. X5 is the small airway obstruction. Lung elastance, compliance, and the lung heterogeneity is depicted by that. And AX, see, this is the delta curve, which is what is happening in the distal portion of the lungs. Both the small airways and the lung parenchyma is depicted by the AX values. Frequency resolution, and that is, we spoke about the compliance and the inert infactants and why they are depicted in the negative form and why in the positive format, right? That the phase shift from negative to positive is the frequency resolution, and that to the X and Y mark will give you the resistance and reactance FRES, which is the airflow obstruction and the lung restriction is depicted by that. Let's look at the altered pathology and in response to your R5 and R and X values. So in a normal lung, you have both resistance and the compliance factors normal. In case of a damaged alveoli, the R factor will still remain there because it is picking up the resistance of the airways. If X, the parenchyma is involved, that is when the X number becomes more negative. In case of airway obstruction, the elevated R, the R factor will be more, whereas the X or the compliance will still remain normal. In case of obstruction as well as damaged alveoli, both R and X are increased in number. Let's look at the asthma. In this case, we may have both R5, R20, R5 minus R20 both are increased. X5 may be increased, and frequency resolution will be shifted to the right, and the AX will be naturally be increased at that point because the AX values, the X5 values go up, and the FRS goes up, the AX goes up. In COPD, in patients with COPD, they tended to show a greater increase in R5, particularly R20. Particularly R5 compared to R20. For this reason, R5 minus R20 is more often elevated in COPD. X5 changes are more negative and frequency shifts to extreme right with increase in AX. Severity can be graded accordingly. In case of small airways disease, the R5 is significantly increased, whereas R20 will still remain normal. And R5 minus R20 is greatly increased. AX goes up and FRS also goes up. And let's understand what the predicted values in adults. It largely depends on the age, sex, height, and ethnicity, and many factors in spirometry up to 70%. The same factors what affect the spirometer also affects the oscillometry as well as age, gender, height, and weight contribute only to 10 to 20% of the variability. It's mostly the height which influences in oscillometry. The cutoff values which are used for adults, R5 minus R5 is about 4 centimeter of water, R20 is 3, R5 minus R20 is 1, X5 is 1, AX is 4 centimeter, and FRS is 12. And we'll have one situation where the R5 is increased by about 54% and R20 is increased by 70% and R5 minus R20 is 0. So this is more like a central pure large airway obstruction. And in case of situation 2 where you have R5 is increased whereas R20 is normal, almost normal, whereas R5 minus R20 is greatly increased. This is very typical of small airway disease. And we have another case where we have both R5, R20 and R5 minus R20 all are increased, which is suggestive of both large and small airway obstruction. So let's understand the relevance in pediatric age group. Response to bronchodilata is more important in pediatric age group. Significant changes in R5, that is R20 to 20 to 25%, X5 of 40%, and AX of 50%, and leftward shift of FRS and reversible is these depict the reversible airway obstruction. Where to use provides useful information regarding subtle changes in the airways and with greater sensitivity. And also he is used to pick up the small airway disease to assess the abnormal distal airway function in case of clinical suspicion with normal spirometry.